The Monkey Audit, Monitoring Knockbacks in Emergency. Hi, my name's Lee. I'm an ED physician here at the Austin. Together with Soham, one of our registrars, we conducted a simple audit earlier on in the year, looking at patients who were referred for an admission, but then declined by an inpatient team, otherwise known as a knockback. And we wanted to find out what was happening here at the Austin, because we believe that this practice may be contributing to disposition delays and ED overcrowding. So very simply, what happened to patients who were declined an admission? Did they actually go on to need a long admission beyond 24 hours, transfer, or some other intervention that we could not deliver in ED, such as surgery? And secondarily, what were the reasons behind these knockbacks occurring? So we, over a 4-week period, looked at all patients that clinicians submitted to the sealed monkey boxes whenever they encountered a knockback. These are the results. We had 67 patients in total, and most of these patients ended up needing an admission beyond 24 hours, surgery, or some other intervention that we could not deliver in ED. Only 2 patients were discharged within a day by ED or the admitting team without actual changes to their ongoing management. Most of the time it was registrars and HMOs in ED who encountered the knockbacks from the inpatient teams. And it's pretty noteworthy that up to 4 inpatient teams were consulted or referred these patients. And this back and forth process is significant because 2/3 of the time, or in 42 patients, the eventual admitting unit ended up being the initial unit that was referred by ED. When we look at the reasons for this occurring, most of the time the inpatient teams wanted ED to refer to another team. Sometimes they wanted more tests to return, and sometimes they wanted personal review prior to accepting the patient. Again, noteworthy that there were instances where all 3 of these reasons applied to the same patient. So unsurprisingly, most of these patients ended up staying more than 4 hours in ED, and almost half of these patients ended up staying more than 10 hours in ED. The limitations to this study are briefly mentioned here in this slide, but more importantly, what can we learn from this audit? The knockbacks may reflect an increased workload throughout the whole hospital system, but there are recurrent themes for patients, as listed here. We also noted that although most inpatient teams were happy to provide advice, some of them were not as happy to accept care or have the patients admitted under their inpatient team. And this is something that we need to investigate further. So where to from here? I believe that we do need to look closely at the referral admission process so that we can better care for our patients and streamline the admission process. Thank you.